Good morning, everyone. Hearty welcome to this Pediatric Cardiology Symposium. Today, in this Pediatric Cardiology Symposium, we have eminent pediatricians from Vijayawada and a group of panelists who are going to address few case scenarios which we see in our routine day-to-day practice of a pediatrician and a cardiologist. So we have the session would go like that there are 3 presenters from Ramesh Hospitals, 3 pediatric cardiologists, and the 4th presenter, our cardiac surgeon, Dr. Bharat Siddharth. He will talk on curable heart failure once the case scenarios are done. So heartily welcome the panelists on the stage, senior and moderators, Pediatric Cardiology Symposium. So to start with, we will start with Dr. Vasudev, who is he would a few case scenarios. He would present the case. Then we moderate it and ask the panelists, eminent panelists, and how would they like to manage this. Then he would summarize what should be the treatment options for these children. So we start off. Welcome, Dr. Vasudev. You can start off with your cases.
Good morning. Welcome to all the panelists, moderators, and the audience. So we'll be starting our Pediatric Cardiology Symposium. So it will be an interactive session. We'll try to make it as lively as possible. So we have taken scenarios which we see in our daily practice, very practical scenarios. So let's start. So we'll start with the scenarios. So this is the first scenario. It's a 10-year-old boy. He was a well child. He went for swimming at 8:30 a.m. in the morning. After swimming for 45 minutes, he came out of the swimming pool, and then he was having some dizziness, weakness, and they noted he had some cold, clammy skin and he was sweating. This is after swimming. So it was something like a near collapse. So they went to a local doctor nearby. They he just saw that, he found that blood pressure was on the lower side. He improved. They started some saline and fluids and he improved. So on probing further in the family history, there was the grandfather had died at 50 years age in sleep. But he was a smoker and alcoholic, so we don't know it was ischemic heart disease or something like some sudden cardiac death. So examination, nothing abnormal. So we'll start the discussion. First of all, should you worry? So can it be normal?
Yeah. Sir, TC Reddy sir, can this be, is it normal or abnormal? How would you do it?
So after 45 minutes of swim, he comes out of the pool and then he collapses.
Yeah, it's a very, very common scenario we see in our day in and day out life. It can, because always common things are common. A normal child, here if you go to the history, child had come to swimming at 8:30 a.m., probably would have come without breakfast, had 45 minutes of swimming, which is reasonably rigorous exercise. So it can be these manifestations can be a normal event like hypoglycemia or dehydration, especially in these summer months. So, however, with the history of early death at 50 years, as far as the grandfather is concerned, may suggest a underlying genetic cause, which can be cardiac or non-cardiac. I think we need to explore that. So I think all we can say is it can be a normal manifestation, but with a note of caution.
Yes, sir. Great. Thank you.
Yeah, history-wise, two clues for cardiac cause for this scenario are, number one, exertional collapse. So 45 minutes of swimming on collapse. So exertional collapse is one of the important clue on which we have to think of some cardiac element. And another important clue in the history was like premature death in the family member. So these two important clues give us some cardiac element would be there for the reason of for the collapse. And probabilities would be like primary rhythm disturbances, like long QT syndrome, classically presents after vigorous swimming. And any other structural heart disease that have been missed or undiagnosed structural heart disease, like especially cardiomyopathies. So that might be the cause for sudden cardiac deaths, like HOCM with left ventricular outlet obstruction and dilated cardiomyopathy. These can have arrhythmias and sudden collapse. And coronary artery abnormalities can present with ischemic symptoms.
Exertional, because we would like more of a cardiac.
Cardiac element.
Dr. Ashok, can you think of any non-cardiac possibilities as an intensivist, as a pediatric intensivist?
So, as T.C. Reddy sir has already mentioned, the most common cause which can be a non-cardiac cause is hypoglycemia. And next is heat stroke because of the raised climate presently which is going on. And the third possibility is out of all non-cardiac can be a vasogenic, cardiac vasogenic stimuli which can cause a syncopal attack, which is almost like that. And one more entity can be because of any toxin inhalation. For example, if the patient has taken some toxins like alcohol, marijuana, or any barbiturates, can cause dizziness or syncope. And one more possibility is, apart from the most common which we should be evaluating for a syncopal attack is seizure. So that can be, and one more possibility is anaphylaxis also can be a reason for where a patient becomes unconscious.
Thank you. Yeah, Dr. Shalini, can you tell me, like, how would you like to approach this case?
So, common things first. So, the basic investigations like ECG, chest X-ray, and 2D echo, I think, to begin with, because we are thinking in terms of cardiac, isn't it, first? So, on ECG, especially, we have to look for all the waves, and especially for long QTs, if we are considering this as an etiology. Calculate the corrected QTC interval, and then we know the normal range, we know the values, isn't it? And then also the chest X-ray is a very basic investigation. 2D echo to look for other etiologies, like for example, if it's a dilated cardiomyopathy, or and to look for cardiac function, any other etiologies. Further testing would be like MRI, if you are thinking of cardiac MRI, to look for if it is HCM or arrhythmogenic. Yeah, these basic things.
So you have completed the list. Vasu, how did you evaluate this case?
So the father had only one question: can my son do swimming in future? He kept on asking, can my son do swimming, or I should stop swimming? So let's see what happens. Slides?
Next slide, next. The slides are gone, please. Audio, video, please. Slides. Okay, it's okay. Vasu, it's seen here. Vasu? Vasu.
Okay. So we also thought in the same lines. Initially, we thought must be some hypoglycemia or exertion related. It's very hot here, so there's a possibility of heat stroke or sunstroke, possibility of vasovagal syncope, or remote possibility of seizure, because they never said that he lost consciousness. And finally, we are all cardiologists, so we always think of cardiac conditions, cardiac syncope. Yes, you picked the clues right. There was early death of grandfather, exertion related. So let's go further. So we did a echo, basic echo. It looked normal. You see all 4 chambers are good, pumping well, function is good. So this is the first ECG. After the echo, we did ECG.
Any abnormalities? What have you?
They are not able to. heart rate of around 58, sinus rhythm, PR normal, QT interval was 368 milliseconds. So it didn't look abnormal. But only thing was the heart rate was very low. If you see, for a young 10-year-old boy who is doing well, baseline heart rate of 58, something was not right. So were we missing something? So then what we did, because all the symptoms was doing swimming. So we subjected him to an exercise test, a treadmill test. So then we started looking at the ECG. So he still had sinus rhythm. Heart rate went up to 130 per minute, which is normal. So after exercise, heart rate goes up. So there is no chronotropic incompetence, or the heart rate has gone up well. Then if you see the QT interval, that got prolonged. So QT interval is 530 and QTC is 527. So the exercise test or the treadmill test unmasked a latent long QT syndrome. So if we don't do TMT or we miss the ECG, we would have missed this long QT. So this is his first episode. Second episode may be fatal. He might not even survive. So that is the importance of doing ECG in every case of exertional syncope and even a treadmill test. Many of the times it will unmask a latent long QT syndrome. So very briefly, long QT syndromes are channelopathies. Actually, there are genetic defects. So gene defects. These defects will cause abnormality in channels. So cardiac channels. So this is the normal sinus rhythm. So as he starts to swim, so that there is a diving reflex, cold reflex, epinephrine release, and all these are thought to cause arrhythmias. So how do we manage? So beta blockers are the mainstay, and sympathectomy is done. So I'll tell our surgeon to tell more about it. So even after all the drugs and all the procedures, if it's not controlled, we implant ICD, implantable cardiac defibrillators. So what as pediatricians and what we can do is avoid all the QT prolonging drugs. So we know already he has a long QT, so we should avoid all the drugs. There's a long list of drugs. And there's no diving, no swimming, no competitive sports. Till this condition is corrected, or you have put an implant, or his QT comes to normal, or you have done a sympathectomy or ICD. So till that time, there is no diving, no swimming, no competitive sports. So next, our surgeon, Dr. Bendik Raj sir, is there to tell something
do you have
about
any surgical management for long QT?
Long QT syndrome is a very interesting thing. For example, you saw this child had something like a heart block when he's normal. And when he exercises, he gets a normal sinus rhythm, which is on the higher side. Long QT is unmasked. And then you get R on T phenomenon, which goes into VT. Am I right?
Yes, sir.
So when R on T phenomenon happens, it's usually because of the irritability of the myocardium. So how do you reduce the irritability of myocardium? Dr. Asirvadam, who is one of the professors of arrhythmias in the US, I listened to his talk where he described how the left-sided sympathetic plexus, thoracic sympathetic plexus, innervates the heart and gives it increases the irritability of the myocardium, and therefore is one of the etiologies for atrial fibrillation and for ventricular tachycardia in these not the right. From the lower half of the stellate ganglion for 3 ganglia removes this sympathetic innervation to the myocardium. People tried cold coagulation, heat coagulation, but that didn't help. So removing the lower half of the stellate ganglion reduces the chance of Horner syndrome. So the lower half of the stellate ganglion along with the next 3-4 ganglia prevents or reduces the amount of irritability of the myocardium and thereby prevents the frequency of ventricular tachycardia. Because if you have seen a patient who's had an AICD, an implantable cardioverter defibrillator, every discharge is a terror. They get a huge shock and they fall down. They are afraid of the next shock. And the battery runs out with every shock. And these children have it. So an AICD's life is extended when you do a left side thoracic sympathectomy. If you do the sympathectomy on the right side, it alters the balance and you come back to square one. Okay? So only a left side thoracic sympathectomy can be done very comfortably through a mini thoracotomy incision or through thoracoscopy.
Thank you, sir. So we had a couple of cases where we have done left thoracoscopic sympathectomy and we had good results post long QT syndrome. So thank you, Dr. Vasu. We have, you have to fasten up, okay? There are 7, 8. So let's go to the second
Moving a
scenario.
little fast. 3.5 months old, was well till 2 days back. Cough cold for 2 days. Noted poor feeding, sucking for 1 day. Lower chest interactions for 1 day. It was very dull, but cold peripheries noted by the grandmother. Very dull child, but whenever you go to examine, he was very irritable. So had cold peripheries. Pulse was feeble but felt. Prolonged CRT. Liver span was normal. Heart sounds were not clear, but very fast heart rate. So let's go to the discussion. So what are we dealing with? So
Is it
at this
cardiac
point,
or
is it
respiratory?
cardiac or respiratory?
Hemkumar, sir?
It's in infant, respiratory distress could be of respiratory origin or cardiac origin. As a clinician, it is sometimes would be difficult to differentiate between these two causes of respiratory distress. The important clues that are mentioned in the history are feeding difficulties. Feeding difficulties like excessive forehead sweating and suck cycle, these can be equivalent to the exertional dyspnea. So then that gives us a clue to stress, and the clinical examination clues towards cardiac cause are extreme tachycardia. Like if it is infant, more than 220, and if it is older children, like more than 180. Extreme tachycardia can give us clue towards cardiac cause, and presence of hepatomegaly and basal crepitations also, and S3 gallop. These are the important clues in the examination and history as well towards a cardiac cause. So in this child had feeding difficulties and extreme heart rate. So probably the cardiac reason might be the reason for respiratory distress.
There was significant tachycardia and gallop, so it's probably more to cardiac. Dr. Shalini, can you say, like, what would you do with such tachycardia as per PALS protocols? How would you approach this case?
So we should, we can't ignore this kind of an extreme tachycardia, especially in a child who is presented with poor pulses, shock, hepatomegaly, etc. So I think first of all, we should try to obtain an ECG and see for all cases of tachycardia. Do the basic things like fever management, and if the patient is shocked, hypovolemic, a bit of fluid correction, and all the basic things first. And despite that, if there is tachycardia, try to get an ECG and then see. I mean, again, as per the PALS algorithms, if it's a narrow complex tachy, or if it's a broad complex tachy. Narrow complex, again, it's sinus. Most common is SVT.
Yeah, we should take an ECG definitely for what is the cause of this thing.
Yeah.
So though it is a bit difficult to record an ECG in infants, we have to take that extra effort and try to find out the cause. Okay, Vasu, have you done the ECG?
Yeah, yes, sir. Next year. So yes,
Okay.
ECG should have been done first, but even in our setting, sometimes it takes time. So we
So he has the echo. Vasu has the echo. Can you play
so
the
we
echo?
started with the echo. So if you look at the echo, it's a 4-chamber view. Heart is very fast, beating irregularly. You see some leaks. Mitral valve, tricuspid valve is leaking. Function is not that great. So sometimes when it is not that good,
There is
so you get
ventricular
these leaks.
dysfunction. Tachycardia with ventricular dysfunction. Next.
So this is the left ventricle. So you can see it's beating fast, irregular, not contracting well. So we measured the heart rate. Heart rate was around 201. So before going to the ECG, so we had a diagnosis. It's probably a cardiac arrhythmia, fast heart rate leading to heart failure, which is tachycardiomyopathy. So then we did an ECG. So this was the first ECG. So 12-lead ECG was done. So we'll go according to the PALS. So the heart rate was around 280 per minute. So QRS duration 80 milliseconds. P waves were not clear. So at this point, according to PALS, it will be fast heart rate, supraventricular tachycardia with pulse. So what did we do next? So IV access was difficult. So we attempted cardioversion, but there was no change or no response. So we finally obtained a EJV access, gave adenosine, but still no response. Sorry, I don't have those ECGs. So then we started metoprolol in our ICU, IV metoprolol. So if you slowly see, so as we started metoprolol, the fast rate towards the end is slowly becoming sinus here in this end last QRS complexes. So metoprolol was working. So we continued on oral propranolol after that and gave oral flecainide. So after 24 hours, you can see the ECG is in sinus rhythm, normal PR wave, normal PR interval, normal P waves, all that was fine. So again this child had a similar recurrence after discharge. So we did something called web cardio, which is a Holter. So in that we could see, so this was at 5 o'clock. So this is sinus rhythm. So at 18 hours, you can see so the rhythm is becoming fast and again getting converted to sinus. So there is waxing and waning episodes. So at times the heart rates are fast, at times the heart rates are slow. So that was the course. So what are the learning points? So if you go by Pulse protocol, as per our case, fits into narrow complex tachycardia, probably SVT with pulse, probable SVT with pulse, but adenosine and cardioversion did not improve. So moving one step ahead of pulse. So after this, there's no guideline in pulse. So once you have done with adenosine and cardioversion, so if it doesn't improve, so the next step is to think whether it's a reentrant arrhythmia or an automatic arrhythmias. So reentrant are fixed heart rate. Usually they respond to adenosine and the cardioversion. So, but in our case, it didn't respond. So it was an automatic tachycardia. It was actually an ectopic atrial tachycardia. So, which is an abnormal focus in the atrium, which was causing fast heart rate and ventricular dysfunction. So with beta blockers, it improved. So we'll move to the third scenario. So moving away from the arrhythmias or the long QT. So 2.5 months infant with failure to thrive, admitted twice already with bronchopneumonia. Somebody had seen the X-ray and echo and diagnosed as a heart problem. So the first thing is whether this respiratory distress is due to the lung problem or left heart disease. So that's our question first.
Yeah, Dr. Ashok.
Sir, going into the history, 2.5-month-old or admitted twice for pneumonia doesn't fit because usually they look at, all newborn babies are looked at pretty safely by parents, and a child who has been having 2 pneumonias, that per se is an indication that, okay, there's something wrong. So definitely cardiac has to be ruled out. But again, in between the episodes of admission, how was the baby? Was the baby active? Was the baby having any issues, persistent tachycardia or tachypnea in between? Again, leads into some cardiac region rather than respiratory issues. So definitely this case, or 2.5-month-old with 2 pneumonias, I think definitely cardiac lesion is the primary cause. So that needs further evaluation.
Yeah, we would look at, and what would be the features or like what clinical cues you would get for cardiac etiology, sir?
Yeah, the clinical cues has to be one history as well as the general clinical examination. Historically, as this child, we know it suggests a cardiac etiology on basis of recurrent. Already child had 2 episodes of pneumonia, and on the top of it, there's a little bit of not gaining weight. If FTT is not a word that should be used,
yes, sir.
It should be failure to gain weight. And clinical examination may throw, historically there may be a suck, swallow in cycle
of heart failure,
variation,
like
sweating while feeding,
yes, sir.
and mother can tell a dynamic precordium. When you do a clinical examination, you may find a murmur, you may find a dynamic, hyperdynamic precordium, sweating. Of course, your heart sulcus takes time to manifest. Yes. It may not be seen now. There may be associated engorged veins and hepatomegaly. These are the clinical cues which may suggest an underlying clinical
predominantly, it's predominantly a cardiac, most probably a cardiac. Dr. Ravi Kumar, how will you approach this case?
Sir, if it is pointing towards a cardiac etiology, as we discussed, we need to start the child on decongestive measures initially, treat the heart failure first, IV or oral Lasix, depending on the clinical condition of the child. and then if required some oxygen support. All the decongestive measures we need to continue, and then if the child infection, there can be some respiratory infection as well for precipitation of the current condition. Once the infection is controlled, then we'll have to go for a definitive cardiac surgery.
Great. So we go for further evaluation, definitely would refer.
Further evaluation was done. This was
X-ray
the
was
chest
done.
X-ray. So sight is not clear, but very big heart. It's huge heart occupying the whole of the left thorax. So definite cardiomegaly. So it was right. There was a heart problem. So we did an ECG. So ECG shows sinus rhythm. So if you observe, this ECG is like an adult MI pattern. So you can see AVL, lead 1, AVF with deep Q waves and V5, V6 with T inversions. So this kind of a adult MI pattern in a small infant should always ring a bell in the mind. So there is something underlying heart problem is there. Some kind of a ischemia is happening in the heart. So that is responsible for the heart failure. So this was the heart. These are still images. So if you see the 4-chamber, thin dilated left ventricle. So the whole of this LV, if you see, this all hyperechogenic. So this scarred myocardium actually. So
echo showed severe ventricular dysfunction, and in this echo we can see that the anomalous origin of the left coronary artery from the pulmonary artery.
Okay, so this was the parasternal. You can see the right coronary very clear. So
yeah, next Vasu.
Yeah, as we go, you see that the left coronary is actually arising from the pulmonary artery.
So the echo, there is a severe ventricular dysfunction in this
severe
patient,
LV dysfunction is there.
The ECG was classical for Al-Kappa.
So the learning point is, before you label as dilated cardiomyopathy or a heart failure, be 100% sure. You exclude all the treatable causes, inborn errors, dyselectrolytemias, in all arrhythmias, and only then we should label as DCM.
Yeah, thank you, Dr. Vasu. So Al-Kappa is a very commonly missed diagnosis. If we don't do an ECG, we can miss this child. So once he is operated, this patient would definitely do well. This child was subsequently operated, and the child is recovered and is having a near normal ventricular function. So next we move on to Dr. Jyoti Prakash. He is our other pediatric cardiologist at Ramesh Hospitals. We have another 3 scenarios.
Okay, good morning everybody. So the scenario 4 is 3 years child with SVT at the referral hospital. So he treated with IV Adenosine at the referral. Then he was started an oral digoxin and referred to us for further management. So at admission, this is the ECG of the child. So anybody would want to comment? Hem Garu, so how often you see this kind of SVTs at your center?
Yeah,
Sir, anything, Hemkumar sir, what you would see in this ECG?
Yeah, this is after converting into the sinus rhythm, any supraventricular tachycardias, after converting into the sinus rhythm, we need to evaluate for most common cause of SVT is re-entry tachycardias. So among them, we need to rule out WPW syndrome to plan for further maintenance therapy.
So this ECG shows some pre-excitation.
Delta waves and shortened PR interval.
Yes.
So it could be like WPWP syndrome.
Great. Yes, sir. There is definitely some pre-excitation which we can see, and delta waves which are this thing. So if a child with SVT comes to the hospital, Dr. Shalini, how would you, the child is on having a tachycardia and narrow QRS, so how would you approach that patient?
Yeah, so child with tachycardia, again pulse, and then do an ECG, look for narrow complex or wide. So here we have SVT, a narrow complex, and we have confirmed it's not sinus tachy, but it's SVT. So then it's again a pulse algorithm, look for hemodynamics, if it's stable or unstable. If it's a hemodynamically unstable SVT, then we have to go for cardioversion, a synchronized cardioversion with the joules of 0.5 and then 1. But if it is a hemodynamically stable SVT, then I think we should role allocate here our nurses. So one nurse we can try for vagal maneuvers using water, ice, cold water, and
vagal maneuvers.
And while the other nurse, you tell the other nurse to prepare drop drugs for adenosine, and then role allocate to the third person to get an IV or an IO access. And always remember that it has to be as close to the heart and it has to be in a large vessel, the IV access. And
good
then,
IV access.
Yeah, and then go as per the algorithm.
Okay.
So this is a kind
One
of
second,
approach.
Prakash. Durga Prasad sir wants to answer.
We have tried actually IV infusion of endosin rapidly in for converting SVT. Once we saw that it went into atrial fibrillation. So it is justifiable to do it in a peripheral center, to do IV rapid infusion of endosin for SVT. Is it really safe, or it should be done only in places where a DC version is available?
Sir, generally if you are when you are giving a rapid adenosine, you should have a defibrillator right next to the patient. We can end up in ventricular fibrillation, so that we have to cardiovert. So generally when we are giving adenosine, it is always safer to have a defibrillator, sir.
Though adenosine, it increases the chances, even in WPW syndrome also, the adenosine can initiate VF. But still there is, as per guidelines, that is the first choice for even WPW syndrome with SVT. So because it is very transient and it will not create the hemodynamic instability. So, but here the question is whether digoxin, they started at digoxin. So is it the right treatment? So usually it is better to avoid digoxin unless until you have the ECG which is suggestive of no pre-excitation. So then only we have to start on digoxin. Okay, just as like sir.
Digoxin versus beta blocker for maintenance.
It's mostly a beta blocker, sir. When there is pre-excitation, that's what he wanted to mention, that when there is pre-excitation, you should avoid digoxin. Yeah.
It's always the beta blockers are the first session. In pediatrics particularly, less than 1 year propranolol, more than 1 year atenolol. That's it. Beta blockers are the mainstay.
They are quite safe.
Digoxin can be like adjunctive therapy, not like means first line. So this is one of the vagal maneuvers I just want to show you. So just watch the video for 2 minutes. So this is actually we can practice on about 10 kgs child.
Prakash, this is adult, we can.
Okay. So here we actually advise them to do forcefully blow against some syringe or anything. So and we'll advise them.
Prakash.
First, sorry. So yes, adenosine is in case of refractory conditions, we can go for amiodarone, procainamide, other beta blockers, and always avoid, try to avoid verapamil because of its potential serious adverse effects. We generally routinely verapamil won't advise for the pediatric age group. Okay, this is as like marks. So another scenario is 12 years child, dyspnea on exertion since a month, and there was no fever history in the past and significant history. And the child is diagnosed at infantile peridiasis cytosynovitis with dextrocardia and mentioned like no structural heart disease. Severe LV dysfunction, and she was treated as like idiopathic DCM at the referral hospital. Radial pulses. So there is a pansystolic murmur and auscultation. So this is her routine X-ray.
Yeah, it was a dextrocardia X-ray with cardiomegaly. Echo shows severe ventricular dysfunction. TC sir, how common do you see ventricular dysfunction in your practice? Otherwise a well child.
LV dysfunction, definitely we are seeing in significant numbers.
It's quite common.
Probably we are adopting POCUS, point of care ultrasound, more frequently. That has become a very important armamentarium in our initial evaluation of any child admitted in ICU. So that's the reason we are able to pick up many cases. But when it comes to the etiological cause for that, a significant chunk are non-cardiac things. Say, for example, in neonate, it may be secondary to underlying hypoxia. Say, if it is a pediatric child, any viral infection can have the associated LV dysfunction. dengue can have LV dysfunction.
So it's quite common to have.
Especially MIS-C is one of the new entities, which present with or which have associated LV dysfunction. So it is not all that uncommon. We are definitely seeing in good numbers, and definitely early recognition of the LV dysfunction is helping us manage these cases in a better fashion.
Especially with point of care ultrasound and lot of intensivists, definitely we have the diagnosis is getting this thing. So Dr. Ravi, what are the routine causes? If you can summarize in short, 5 common causes you see as a ventricular dysfunction in your ICU?
Yes, sir. The common causes are the acquired causes, sir. They can be infection related, like as sir said, viral myocarditis is the most common thing. And the other common thing which we see in our pediatric intensive care patients is septic cardiomyopathy, dengue cardiomyopathy, and sometimes some infiltrative diseases can also cause, like glycogen storage disease, especially Pompe's disease. Even mucopolysaccharidosis, the other infiltrative diseases, they also can present with cardiomyopathy.
Dr. Prakash, how did you go about this case? It was a severe ventricular dysfunction in an older child.
Yes, this child is having anyway ejection fraction is around 21%, so it is severe LV dysfunction. So, but actually we got a clue, like in the descending aortic Doppler, there is a dampened descending aortic circulation. So it's not like a pulse style flow.
So what could it be from any Dr. Shalini, non-pulsatile descending aortic Doppler with ventricular dysfunction, commonest cause, what you would think? We would look at, Dr. Murtaza, probably we would look at coarctation or any obstructive aortic disease, because the descending aortic Doppler is non-pulsatile. Yeah. So Prakash, we thought you look for the arch. What is the coarc? Is there any coarctation?
Yeah, there are 2 possibilities, like a coarctation, like which is a congenital one, and acquired conditions like Takayasu arthritis, where you can have like both. It's like it can sometimes they mention like a pulseless disease or acquired coarctation.
Great, yeah.
So this child, after CT imaging, it was showing that there is diffuse descending thoracic aorta coarctation. So it is narrowing of that.
It's a middle aortic syndrome, like Takayasu arthritis. It was not a coarc.
Yes, it is a Takayasu arthritis.
Okay, you did an angio and which showed tightening of the middle aortic area.
Yes.
So this was the cause of ventricular dysfunction. So there was some obstructive lesion. So, and were the renals checked? What was the CT report of the renals? Sometimes middle aortic syndrome.
Renal, bilateral renal arteries. Actually, I forgot to add that image, but bilateral renal arteries are actually normal.
Yeah.
So this is a good sign for the child. So it was diagnosed early. So after immunomodulation, the child is improved much.
Oh, great.
So these are the causes for anyway many of you know. So cardiac failure. I am going for next scenario.
So just if you want to summarize that case, it was a treatable cause of ventricular dysfunction.
One of the treatable cause for ventricular dysfunction. So before labeling this, just like Vasu mentioned, before labeling like it is idiopathic dilated cardiomyopathy, always better to diagnose, better to evaluate for the treatable causes. So after ruling out the treatable causes, then you can label for idiopathic dilated cardiomyopathy. So this child was treated for more than 3 months with just diuretics and so on. But after immunomodulation, child had improved.
So good imaging and further evaluation would help this
Yes,
patient.
this child needs, as per latest guidelines, it's like the lifelong follow-up for the child.
Yeah, we need to follow, but it is definitely LV dysfunction is improved. Can we go to the next scenario? We'll have to be quick. Yeah, we'll take 15 minutes.
This is a scenario 6. 4 days neonate admitted with RD at the first day of life, but in the first 24 hours evaluated by technician with for cardiac evaluations, they suggestive of like mild LV dysfunction, but otherwise normal. So because of the so there was nothing. So but after on day 3 there is again worsening of the hinotrope necessity. So the neonatologist asked pediatric cardiologist consultation because he had the other lab parameters are grossly elevated. Then inquired for this, where there is no history of contact for the mother, but history of COVID immunization at 7th month. And the anti-SARS-CoV antibodies for the child are more than 120. So you can see the image. This is
so this is a very common
grossly dilated.
Yeah, this quite common. I'm sorry, I'm interrupting because they have been pushing me for the time. So this is a new scenario in the post-COVID world, what we call as a MIS-C, which we are seeing infants involving coronary arteries or something like a Kawasaki-like disease. So TC Reddy sir, just in short, how you would have seen quite a few cases and you have published. So what is your opinion on that?
Yeah, this is definitely a new entity we are all encountering. It is aptly called MIS-N rather than MIS-C because since we are now talking about a neonate, any deviation from the routine expected course in your treatment of a neonate should definitely caution you with respect to this condition because we have seen almost 25 cases till now. We have published 18 cases, case report also. One of the very common, frequent associations with this entity is fever. Because fever, almost 75 to 80% of the newborns have at least a couple of spikes of fever. That should caution you, first point. Number two, document COVID antibodies in the mother. At the same time, a proportionate antibody IgG in the child with IgM negative as well as PCR negative in the child. That should drive you to a diagnosis of MIS-N. This coupled with associated elevated inflammatory markers and multiple system affection. Especially we have seen a significant association with pulmonary artery hypertension, which is disproportionately high in these cases. The most gratifying thing is they respond beautifully to your IVIG.
Yes, sir. So once you diagnose, you give IVIG, they are normal.
Yes. And one more point of almost 25% of these cases we had associated pneumothorax, not maybe 20%. I don't know why this entity of pneumothorax, I'm not sure.
Yes, sir.
Sir, this child doesn't have, the mother doesn't have any history of COVID. Only history is COVID immunization at 7th month.
What is the antibody levels in the mother?
Actually, we missed that part. So definitely. So now, would you recommend for the mothers all routine immunization because this is approved? COVID immunization is approved in pregnancy also.
Yes, yes.
But
yeah, I have a small submission. This MIS-N is significantly more common in mothers who had active COVID infection. The association of MIS-N with respect to COVID immunization in the mother is far less. We don't, especially you can see in the second wave we have a lot of cases of MIS-N, but with respect to the third wave, hardly 2 or 3 cases, that's all. So probably the nature of antibodies produced with respect to immunization is different from what is elicited with respect to active infection. That is my speculation. I am not sure, but this may only, and Western studies have suggested this also. So immunization should be promoted in the mother also, in pregnancy.
Thank you, sir. They are actually pushing us on the time. So, okay. Yeah. Murtaza, you will do only one scenario, then Dr. Siddharth will speak only for 5 minutes.
Actually, my scenario is like, good morning all, it will be like more concerned, we are not concerned, it's more seen in adults, but it is also prevalent in the pediatric age group. This is a like 12-year-old child who basically in this COVID season, we have lots of them sitting in the home, they are addicted to like...
Near to the mic.
Online TVs and outdoor games. His BMI was like 31 kilogram per meter square. There was no family history of any sudden cardiac death, hypertension or diabetes mellitus. So obviously this is like obesity. We all know that in children, we define the obesity different as more than 95 percentile of BMI. So definitely this is obesity. So how commonly do we enter this in our OPD practice? Like
I think it's around 30%, sir. Yeah. In my office practice also I am seeing it. It is more now, starting as an overweight at 80 years and is ending at the obesity after 12 years.
Right, sir.
Though we are counseling them, they are not responding. They are only coming with obesity later, then only they are responding it. That is what is happening in my office practice.
Very true, sir. Very true.
It's quite common nowadays, childhood obesity.
Yeah, so this is like even the data suggests that the rise of obesity and overweight is increasing, and it has increased to up to the extent of 20%. Yeah. So this is not very uncommon. Many a times we ignore these cases in our OPD. So should we really have some genetic issues, like there are some genetic causes of obesity, sir. So some of the syndromes like Down syndrome is there, Prader-Willi is there. These are some of the syndromes. And of course there is some mutation in the leptin-melanocortin pathway, which is mainly involved in hunger and energy homeostasis, which leads to hyperphagia and obesity in these cases. We all are aware that long term there is direct relationship of obesity with systolic blood pressure, diastolic, and cholesterol and triglycerides, and inversely proportional to HDL. So basically, how do you tackle these cases in your OPD practice, like in terms of prevention and treatment?
So first we have to know, when we are evaluating it, whether there is only weight gain or a linear growth also. If the linear growth is less but weight gain is more, we have to evaluate for any medical cause. But when both linear growth and weight gain are more, both curves are corresponding, then we have to think about the patient's physical activity. So we have to evaluate his nutritional activity and physical activity.
Right.
And we have to see the daily routine of the child.
Very true, sir.
Usually now what's happening is students are concentrating on the studies from the morning 6 to evening 7. In this total area, they are not doing any physical activity. So in the curriculum itself, you have to need a 1 hour physical activity in the school itself. Otherwise, it's very difficult to control this obesity prevalence.
Right, sir. Even
And in nutrition aspect also, they are not up to mark. They are taking more of junk food, more of screening time, less of sleep also. And the sleep deprivation also will cause obesity. So we have to evaluate regarding all these things, and you have to involve the family also. See, and especially if you ask the child to do exercise and father and mother are not doing exercise, there is no motivation will be there. So you have to motivate the whole family regarding the nutritional aspects and also the physical activity. Then only you can get good outcomes, sir.
Yeah. Those who are around less than 5 years, maximum of less than 1 hour of screen time is recommended. And of course, diet, physical activity.
Counseling
you have
and
already elaborated.
management is very important.
So basically, we should color our plate with different nutrients, like it should have all the nutrients in balanced amounts, including fruits and vegetables. So like these are some of the drugs which have been now FDA approved, like sibutramine, orlistat, and even setmelanotide have recently been approved. So this was like my case. Can I go ahead with another?
We'll skip it.
Okay.
They've already asked to stop. Meantime, when Dr. Siddharth would take up on curable heart failure in short for about 4 to 5 minutes, I would request Dr. Durga Prasad sir to summarize.
One thing which we should remember as pediatricians is fetal origin of disease in particularly the children with low birth weight, small for gestation. Like this is the Barker's hypothesis which you have to remember. So these children which are small for days, they gain adiposity in later part of life. They are going to more morbid complications of CVS. So apart from that macrosomia, which is child born at with high birth weight and maternal obesity and maternal gain during the pregnancy, all these things factors do matter, but this particular factor also, Barker hypothesis, one has to keep in mind and follow these children to prevent cardiac morbidity and mortality in later adolescent and young adulthood also.
Thank you. In short, so Dr. Siddharth is our pediatric cardiac surgeon, full-time available at Ramesh Hospitals. There are a lot of curable causes of heart failure. So as a surgeon, what all magic the surgeons do and cure this heart failure? In short, he would just summarize.
Yeah, I will be talking about surgical success for heart failure. I won't be including cases which will be dealt with VADs or ECMO or transplant. This will be purely surgically treatable and curable ones. Everyone knows what heart failure is. It's basically heart is unable to function as a pump. It has many diverse etiology. I will explain it through one of few case scenarios. We had a 3-month baby who had presented with congestive heart failure. There was no history of fever, no history of cardiomyopathies in the family. X-ray showed a very big dilated heart. This was a picture of the heart with severely dilated LV. The child was being managed as cardiomyopathy at outside hospitals. One of the cardiologists suspected it to be Al-Kappa, and he got a CT scan in which showed that there was origin of left coronary artery from the pulmonary artery. Even despite this echo picture, it's purely treatable cause. We did a coronary transfer, and post surgery the ventricle recovers within a period of 3 months to 6 months. So it's one of the case. The other case, we had a 1-week baby who again presented with severe respiratory distress. The child had got intubated with severe pulmonary edema. You can see the heart, the right ventricle is not at all functioning. It's purely dilated. This was diagnosed to have a TAPVC. We did a surgical repair. Post surgery, you can see the ventricle function. It recovers so well. This was a child later on 6 months. Another case of 1-month child who presented with severe failure. Echo showed severe ventricular dysfunction. Outside the echo had no intracardiac defects, but they missed the coarctation, which was later found on the echo. And this is also a very treatable and curable cause. This is a child in follow-up. So everyone knows the signs of heart failure like growth failure, tachypnea, tachycardia, and always hepatomegaly. There are different causes like cardiomyopathies, secondary cardiomyopathies, which can be treated medically. But what is important for us is the surgically manageable ones, like left to right big shunts, pressure overload due to coarctations, or any severe aortic stenosis, even cyanotic lesions like TAPVC, truncus, and Al-Kappas. These are surgically curable with good results. So you should rule out a surgically treatable cause before labeling it as cardiomyopathies, and early treatment has good outcome. Yeah.
Oh, thank you, Dr. Siddharth. So because we are over time, our management is pushing us to close the session. So just to conclude, we had an excellent session of Pediatric Cardiology Symposium. Thank you to all the speakers and chairpersons. At Ramesh Hospitals, there are 3 full-time pediatric cardiologists, and there are 2 pediatric cardiac surgeons. They do full range of from neonatals to adult congenital and structural heart work. And right, because there are 3 full-time, I think that's the biggest number of post-DM or post-DNB pediatric cardiology program, full-time program, which is there at Ramesh Hospitals. So they are doing excellent work. They have done more than 2,000 cases at Ramesh Hospitals in the last 6 to 7 years. So let them congratulate the team of pediatric cardiology at Ramesh Hospitals and let them continue the good work. So we have a few mementos to be presented to the chairpersons and the speakers. I would request Dr. Nori Sunan sir to do the honors of giving the mementos. To Dr. Shalini, she's an intensivist. Thank you for coming. Thank you. To Dr. Ravi, he is at Ankura Hospital. Thank you, Dr. Ravi. To Dr. Hem Kumar, who is an intensivist at Rainbow Hospitals. Dr. T.C. Reddy sir has come all the way from Guntur early morning. Thank you, sir. Dr. Y. Sai Kishore sir. Dr. Ashok. I request Dr. Benedict sir, you can please give a memento to our chairpersons. To Dr. Durga Prasad sir, senior pediatrician here. And Dr. Nori Surnayan sir. And to Dr. Rajni madam. Yeah. Okay. Thank you one and all. Thank you for the excellent timing and for being here on Sunday morning.